the chairpersons. So today we have a very young, excellent speaker, Dr. Srinidhi and Dr. Balaji, and both are going to speak about the perinatal psychiatry current view and also the licensed psychiatry current trend. And today we have a moderator, Dr. Kailash Sreskumar. Dr. Kailash is the professor and HOD of Chettinad Medical College, Chennai. And Kailash is a very knowledgeable person and he is an academician. He has chaired many sessions in state, zonal as well as national level. With a small introduction, I'll hand over this to moderator Dr. Kailash. Yes, Dr. Kailash.
Yes, thank you, sir. Good evening. Good evening, all. I thank Dr. Panniselvam, sir, TNIPS President, and Dr. P.P. Kannan, sir, for giving me an opportunity to be a part of the program. So today we have two important topics in an area where most of the young psychiatrists are being employed nowadays, because many people are getting employed in general hospital psychiatry units nowadays. So this will be a very important topic. So we will ask Dr. Sabita Madam, Professor and HOD, Chengalpet Medical College. She is an very pleasant person, very approachable, supportive, and she's been our teacher. So I welcome ma'am to introduce the topic to the audience.
Now I am put up in Stanley. Come to Stanley. No, okay, right, that's fine. Good evening, everyone. I think at the outset, I thank the TNIPS and the office bearers and the scientific committee for giving me this opportunity to chair the session. Two important topics are prenatal psychiatry and liaison psychiatry. Usually, there are specific groups of population who suffer from certain disorders, and that too during pregnancy and the postpartum period. That is the vulnerable period in case of females, where the disorders are more common due to the hormonal change, the psychosocial change, what they undergo, and sometimes due to the relationship issues also. So the disorders are very specific to that period. Okay, unless otherwise you tackle it properly. And the challenge is very high, because during the pregnancy and the postpartum, and where the mother is breastfeeding the child, even to medicate or given some medicines, it's becoming challenging. Second thing is, now the bondage between the mother and the child is increasing, which is causing some problems even in the mother as well as the child in bringing up. So the bondage, that is also having some, that is, it's on the highlight now. It's becoming the limelight in the perinatal psychiatry. And regarding the liaison psychiatry, there are some, we call it as psychosomatic disorders previously. The origin, the progression, as well as the outcome of the disease is based on certain psychosocial variables. So unless otherwise you tackle them properly and you address them properly, I think the progression and the outcome of disease is going to be worse, or it's not going to be as expected. So the psychiatric morbidity, it's a comorbidity in these conditions has to be treated properly so that the quality of life improves in them. That's why we are called in many places, actually, for delirium, even in dementia, then during the poisoning, toxic cases, okay, right? And then perinatal psychiatry. So many areas, the psychiatrist is being called upon to address the aggression as well as the psychomotor or the psychiatric comorbidities like that of depression that has to be treated, okay? And it is a developing field nowadays. So the future is going to be in that. And I think I invite both the speakers, that is young speakers, to highlight on this topic.
Thank you, ma'am. On to our first session, which is on perinatal psychiatry, by Dr. Srinidhi. She is from PSG Coimbatore, which is also my UG college. So she has done her MD from St. John's, Bangalore, and finished TNB after that. Worked as a senior resident in Mumbai, and from then on, she is in Koimbatore Medical Center now. She has presented many papers and posters, and apart from that, she is seemed to be a more sort of speaker in many conferences of late. So she is an invited speaker in IPS Kongunadu branch, and she has good interest in women psychiatry, adolescent psychiatry, So these are the areas. So we have a speaker on perinatal psychiatry. So we have a speaker who's has the focus of interest in the topic today. She has also been an invited speaker for addiction and in PSG colleges, and also in Tamil Nadu state level conferences. So, and also in
So I thank IPS for the opportunity for speaking today. And I'm going to talk on the current trends in perinatal psychiatry. So the outline of my presentation is going to be introducing the topic, mental health disorders in the perinatal period, the assessment tools that are commonly used, the intervention and evidences for the same, and how do we decide on an individual intervention, the risk-benefit assessment, the policies and legislations that are currently existing and what could be the policies in the future, and the current limitations the studies hold now before I conclude. So pregnancy and childbirth are dramatic events in the biological life cycle. And apart from the various biological changes that are in the body, there's also intense emotional involvement. And psychosocial risk factors and intervening life events also play a role. So the key factors are both the biological and the psychosocial, which increases a woman's risk for psychiatric illness. So we commonly hear people say, அந்த காலத்துல 8-10 குழந்தைகள்லாம் வச்சிருந்தோம், நாங்கெல்லாம் எங்களுக்கெல்லாம் இதெல்லாம் வரல, இப்போ ஒரே ஒரு குழந்தைய வச்சுட்டு அது என்ன டிப்ரெஷன், அது என்ன ஆங்ஸைட்டி அப்படின்னு. So is it happening because of increased awareness or increased detection? There is our famous even longitudinal study of parents and children, the Bristol study, the children of the 90s study, that actually says the multi-generational, it assessed pregnancies across 2 generations. In that, it is said an average of 51% depression was more common in the next generation compared to the previous generation. So there is also a real increase. And this real increase could be because of other social factors like probably working parents, fast pace of modern life, the technology, the addiction that they get into, and the isolation. And we see more of nuclear families these days. So without, with lack of support, so that these may be the psychosocial contributing factors. And the eyes can see what when the mind knows it. So maybe earlier we were looking at maternal factors, the perinatal outcomes that we were looking were very different. Probably postpartum hemorrhage and which were more life-threatening. So when those were covered with good policies by the government, now we are starting to look at the mental health and the mental health outcomes. So maybe that's why we are seeing increased numbers now. So the perinatal period includes the period during pregnancy, childbirth, and postpartum period up to 1 year. So perinatal mental health disorders are among the commonest morbidities in pregnancy. And it's also an important contributor to maternal mortality and adverse neonatal infant and child outcomes. So the nosological status is in ICD-10. It is classified in mental and behavioral disorders associated with puerperium, not elsewhere specified. And it takes into account onset within 6 weeks of delivery, while the DSM-4 says the specifier as postpartum onset, and it considers onset within 4 weeks after delivery. So it works as a specifier. So either major depressive disorder, bipolar 1 or 2, brief psychotic disorder with the postpartum onset as a specifier. And if it's postpartum psychosis, it is classified under psychosis, not otherwise specified. In DSM-5, the changes, it's included pregnancy also. If you look at the onset mentioned in DSM-4, it's only onset within 4 weeks after delivery. So it actually included only postpartum onset. In DSM-5, we're looking at peripartum onset, where it included pregnancy or within 4 weeks after delivery. So classically, the emotional disorders we were looking at was only during the postpartum period. So the baby blues, which occurs in 50%, it is self-limiting, it is transient, and postnatal depression occurs in 10%, and the increased risk is seen in women with previous psychiatric history, if it was an unwanted pregnancy, first child, other psychosocial factors, and psychosis was occurring in 0.5% and very high risk in women with a previous history of schizophrenia or mania. So this was the emotional disorders that were looked at classically. But mental health disorders in the perinatal period should include the common inclusion that we are looking at now are common mental health disorders and severe mental health disorders. The common mental health disorders include anxiety, depression, OCD, adjustment disorder, grief. This is to name a few. Substance use disorder, all these are common mental health disorders. Severe mental health disorders are bipolar affective disorder, schizophrenia, severe postpartum depression, and postpartum psychosis. So common mental health disorders, it is found more commonly in lower and middle income countries, and it accounts for 15 to 20%. The prevalence rates are about 15 to 20%. And in India, when looked at the pooled estimate in a systemic review, it was about the common mental health disorders in the peripartum period was about 22%. And pregnancy-related stress was about 30.9%, and anxiety was 23%. So roughly to remember, it is around 15 to 20% the common mental health disorders. The main disorders covered during these studies were anxiety and depression. So about perinatal depression, it affects about 10 to 20%, and common thought content centers around motherhood, mostly saying I'm not a good mother, and so the infant is suffering because of me. And there are also other stressful life events and lack of support from the partners. They are also additional risk factors. So the risk estimates these are some things that we have to remember. So somebody with a history of a major depression, what is their risk of developing a postpartum depression? It is about 24%. So somebody with a bipolar disorder, so 1/5 of the people having a bipolar disorder experience a relapse during pregnancy. And postpartum depression, for somebody having first-time postpartum depression, they don't have any previous psychiatric history. The recurrence risk of affective disorder, so later on developing into an affective disorder, is about 15 to 21%. And women who've had postpartum depression, in subsequent pregnancies, they are at a risk of 50 to 60% of having subsequent PPDs. So we are talking about people with previous psychiatric illness, or when PPD going on to have a psychiatric illness. So what about healthy mothers? Because we see a lot of healthy mothers. So this systematic review actually reports. Okay, I'll tell you briefly about the systematic review. So this covered about 30 prospective cohort studies, 26 cross-section studies, 2 case control studies, quite a huge number of women studied, and it included clinical interviews and also self-reports. And it studied mainly the prevalence within the first 3 months. So the incidence of postpartum depression was about 12% here. And the prevalence was different in different geographical regions, where Middle East had more incidence compared to Europe. So this indicates that even healthy mothers, so this is a study done in these are the systematic reviews done in healthy mothers. So 12% of postpartum depression is even found in healthy mothers. So we are mostly looking at populations with previous risk factors, but even without any previous psychiatric history, they are still prone to having postpartum depression. So what about postpartum anxiety? This is again a systematic review where anxiety is shown to be highly prevalent, and the prevalence is about 15 to 20% for antenatal and 10% for postnatal. And it is seen that it increases across the trimesters of pregnancy with a mean prevalence of about 25%. And it's also found, why is it important to understand anxiety? Though most studies are done on depression, anxiety is also highly prevalent. So it is very important to understand the same. And it also causes risk to the outcomes in child and behavioral problems as a result of antenatal anxiety and stress. So it is important to look for anxiety also. So other anxiety disorders are specific for depression can be tocophobia, fear of pregnancy and fear of childbirth. This is a group which delays pregnancy, or they terminate pregnancy, secondary to anxiety. And somatic symptoms may be a presentation of the underlying depression or anxiety, which are most often ignored in the rating scale specific for perinatal period. And generalized anxiety disorders are also prevalent across pregnancy and postpartum. This is trait anxiety, which was highlighted in one of the systematic reviews, where anxiety traits are it's one of the most common personality traits, so anxiety. So 29 to 33% antenatally were actually found to have trait anxiety. And postnatally also quite a few, 20 to 30% had. And this had an impact on preterm birth, impaired maternal bonding, and poorer infant cognition. So we looked at depression separately, anxiety separately. What if it's comorbid? So there is a group where 1/3 of MDD had anxiety, and again 1/3 of anxiety have comorbid depressive symptoms. So what happens? What is the impact? So when it's comorbid, there are more severe symptoms, more difficult to treat, and there are poorer acute and long-term outcomes, and increased risk for suicide, and specific treatment strategies are needed to address both. But what happens? Because hierarchically, the diagnostic custom is where depression takes precedence. So again, here anxiety is not addressed much, though anxiety symptoms might be predominant in the same person having the depression, but depression is given importance because of the hierarchy. But it's important to consider both because of the other impacts that are listed. So other disorders, OCD is also higher in pregnancy and peripartum period compared to the general population. And the specific ones are harm related to the baby and contamination and baby falling sick. PTSD, though childbirth is considered a positive experience, but it's not the same for everybody. So PTSD prevalence is around 4%, and negative experiences of childbirth and the kind of care received in the hospital during delivery can also impact or lead to PTSD. And grief, perinatal loss is another area that we see a lot of mothers in our setup. So culturally sensitive interventions are needed for the perinatal grief. And it has to be addressed differently because it is either a late, it can be even an abortion, it is an abortion or a neonatal death. And it has to be addressed in a particular way, more culturally sensitive way. So among substance use disorders, we know the effect of various substances. Alcohol can cause growth restriction, low intelligence, ADHD, cannabis again, risk of mood disorders and ADHD again, and tobacco, risk of preterm birth. So this can be the impact of substance use disorders in the peripartum period. So perinatal mental health disorders. So commonly the common mental health disorders, the anxiety and the depression, what happens, it actually begins during or before pregnancy itself. But it's less likely to receive treatment because most of the women are very concerned, and there's a lot of scare about teratogenic effects of the drugs. So most of them don't reach treatment or even access treatment. So though it begins in the during or before pregnancy, it is most often addressed later in the postpartum period. Whereas the severe mental illnesses most commonly begin in the early postpartum period. And it was found that women were around 22 times more likely to have a psychiatric admission in the first month following delivery. And this is something interesting that I found. For every 1 woman requiring IP care, it was noticed that actually 2.5 women require OP treatment, and 12 people actually require to receive pharmacological treatment. So what does this imply? So mostly people requiring IP care would be severe mental illness. So common mental disorders actually represent a significant component of treatment needed in the postnatal period, because mostly the OP treatment received by common mental health disorders. So postpartum psychosis is the most severe form of perinatal mental health disorder. It needs specialized settings so that we can room in the baby with the mother and avoid the separation. And catatonia is another common presentation in pregnancy, about 20% seen in pregnancy. So suicide is higher in first year after childbirth, and women are also more likely to use more lethal methods in perinatal period. The other risk factors are younger age, middle socioeconomic status, poor support, domestic violence, depressive symptoms that are comorbid, and history of previous attempt of suicide. And suicidal risk in pregnancy and postpartum has to be looked at along with infanticide risk. So the assessment, moving on to the assessment tool. So we discussed on the perinatal mental health disorders. So moving on to how do we assess it? So these are the common assessment tools like any other disorder that we can apply in pregnancy also. So moving on to specific tools that can be used during pregnancy. So these are quick screening that can be used in, because of the limitation of not all people reach psychiatrists. This can be used in the obstetrics and gynecology OP, and it can be used by OGCs to screen also. The Woolly is just 2 questions on in the last 1 month, have you been feeling low, and have you been having loss of interest? Just these 2 questions to screen for perinatal depression, and they can be further on referred. And Edinburgh's postnatal depression scale, that also can be used. It's also a self-report. And these are other scales that are used in pregnancy. So pregnancy and the peripartum period. So the NIMHANS maternal behavioral scale, postpartum bonding questionnaire. These are used to understand maternal behavioral disturbances. And the postpartum bonding questionnaire is very important because it assesses for maternal and infant bonding. So most of the scales are quite short, and for a research setting or an IP setting in a psychiatric unit, a detailed interview like a Stafford interview can be adopted. It has about eight domains covering both pregnancy and lactation. It takes quite a long time, but it's most often done in psychiatric setups. So what happens if we don't treat a mental untreated? What are the consequences of untreated mental illnesses? So it can increase the suffering of new parents. Suicide is another risk factor, and it affects long-term self-esteem of the person, and it has negative outcomes in children also. So it also leads to, in the antenatal period, they don't seek antenatal care, supplements they don't take, they try to cope up with substance use. There is risk of self-harm or suicide, and there's miscarriage or preterm birth, and there is a antenatal depression is the highest risk factor for postnatal depression also. So interventions, moving on to interventions. So in general, to understand mild to moderate perinatal mental illnesses, psychological interventions are suggested, and severe mental illnesses currently, or history of severe mental illness. So previously had suicidal risk, previously had severe mental illness, have also to be considered for prophylaxis. So this is mainly pharmacotherapy with or without psychotherapy. So why should we treat illnesses? Because high risk of recurrence of severe mental illnesses without medication prophylaxis. It's about 60 to 80%. With medication prophylaxis, it's only about 20 to 30%. So that's why in severe mental illnesses, the prophylaxis have to be considered because the numbers are huge. So perinatal psychological, I'm dividing test psychological interventions and pharmacological interventions. So for psychological interventions, it is seen meta-analysis, the result, robust evidence shows it is effective and cost effective. And most of it is tested for CBT, but there are studies examining interpersonal therapy also. And online CBT also, because given the limitation, early childbirth, and people may be in remote places, maybe they're not able to travel with the child, or there are other demands that they cannot come. So online CBT is still found to be effective. And there's also a psychosocial intervention done by the study examines by supervised non-specialists. So that also was found to be effective, not only reducing maternal depressive symptoms, but also improving infant outcomes in terms of their growth, vaccine, and reduced diarrheal diseases also. So even we can look at online options or supervised non-specialist options for delivering the psychological interventions. So about psychological interventions, there is reasonably good evidence base for effectiveness in the perinatal depression, like in outside perinatal period also. So pharmacological interventions, mainly most of it emphasizes the need for individual risk-benefit analysis, because it's different for different person. And participative decision making always makes the client or the patient more rooted towards the treatment options. So most often they overestimate the effect of drugs, and so they neglect it. But the risk of untreated illness also has to be discussed with the patient, and so they become more participative. So what do we mean by risk-benefit assessment? So the 4 major considerations in risk-benefit assessment are: what is the risk of untreated maternal psychiatric illness? And what is the risk of using medications versus what are the benefits of adequate control of maternal illnesses versus benefits of avoiding medication exposure. So while deciding about use of a particular drug for a particular person, these risks and benefits have to be looked at an individual level. So early on, FDA classification of drugs were used as A, B, C, D, X. So now the classification is more pregnancy and lactation labeling rule. This has come from 2015. So the new rules are based on how do we select a particular drug for a particular person. So they use the pregnancy and lactation labeling rule. So this assesses actually under 3 headings. One is pregnancy-related risk. So in terms of what is the risk of congenital anomalies, what is the risk of untreated illness, and lactation-related labeling, what is the relative infant dose that reaches, does the drug impact lactation, so these kind of considerations, and also what it does to the reproductive potential of male and female. So a drug is assessed based on these rather than the old traditional category. So this has come into effect from 2015. So based on this, we decide a particular drug for a particular person. So I'm going to talk a little in detail about SSRI because common mental health disorders cover anxiety and depression, and the first line of treatment for it is SSRI. So SSRI use has been increased over time. So this study looked at maternal use of a specific antidepressant medication during early pregnancy and risk of selected, what are the risk in fetal outcomes. So this was a population-based study. Mother of babies with or without birth defects were looked at, and this was a telephonic interview in postpartum. And about the use of particular medications were asked. So this is a population-based study. So if you look at the trend from 1997 to 2010, so you can see the commonly used SSRI that we use with relative safety in pregnancy is sertraline. So you can see the sertraline usage going up in pregnancy, and I mean going up over the years. And drugs like paroxetine were still cardiac effects. Most of the studies show cardiac effects, but when confounding factors were removed, they say there is no risk. So but however, paroxetine use has come down. So this actually the trend also follows our current understanding with more use of sertraline and escitalopram compared to other drugs. So I will skip this for want of time. So
yeah, Dr. Srinidhi, 5 more minutes.
Okay. Many selective Many selective serotonin reuptake inhibitor and birth defect associations attenuated after partially accounting for underlying conditions. So this is something that we have to remember. So most of the defects have been attenuated when confounding factors were removed. So actually the basic illness itself causes these risks and not necessarily the drugs causing the risk. So again, for congenital heart defects, the basic illness itself causes the risk rather than SSRI. And similarly, but for PPH and preeclampsia, it was found that there is a small increase in the risk of PPH associated with SSRI use. But however, the clinical significance remains unclear. So the recommendation is to continue SSRI at the lowest dose and not worry about the PPH. And similarly, for preeclampsia, there is a small increased risk, but however, it can be continued. A GDM and SSRI, there's not much risk. And about neonatal exposure, PPHN, there is 0.2 to 0.3% increase in absolute risk, but there is no increase in risk with ASD, ADHD, or and studies for longer outcomes or cognitive outcomes, more studies are needed. So pharmacotherapy, basically to summarize, the SSRIs, sertraline has the least placental exposure, and that's the most preferred drug for anxiety and depression. TCAs can also be used, especially there is high fetal exposure to TCA, but more like amitriptyline can be considered where sleep disturbances are also present. And among anxiolytics, benzodiazepines, SOS use, intermittent use of benzodiazepines can be done. And among the second generation, first generation antipsychotics, second generation antipsychotics have increased risk of gestational diabetes and those risks. But however, olanzapine is considered more. And among first generation, hypotensive with like haloperidol is considered. Among mood stabilizers, second generation antipsychotics are preferred mood stabilizers, but however, if lithium is warranted, lithium or lamotrigine as a mood stabilizer can be considered despite the risk, again, weighing the risk-benefit ratio. So untreated depression by itself causes preterm low birth weight. So again, untreated depression is a very high thing that we have to look at compared to medication risk. So the other interventions, ECT is essential in risk factors of preventing suicide, reducing the risk of suicide, catatonia. Brexanolone is a novel drug, not yet available in India, but there's a 60-hour infusion. The efficacy and safety studied of 60-hour infusion versus placebo, there is a significant drop in depression score in HAM-D. So how do we do it? We have to increase in screening for perinatal mental health disorders. So in Kerala and Karnataka, it's been included in the TAI card, the antenatal record for mothers. And we have to ask them a few questions, but we have a few questions before we screen. So what do we do with people who are positive? Do we have enough help that we can give them? So ideally, we have to include the preconception period because most of the pregnancies are unplanned. So we have to not only look at optimizing the drugs, but we have to look at the health of the person and social support that the person has. And paternal mental health is another important factor that we have to look at because 24 to 50% of the fathers are also affected in the perinatal mental health. And only if they are supported, they can also be supportive to women with mental health disorders. And this is very important for the infant also to have two healthy people looking after them rather than having marital discord because of their own mental illnesses. So the existing programs, the RMN, the Reproductive Maternal Newborn Childbirth and Adolescent Health in 2013 was introduced to cover this category, but it looks at more physical illness rather than a mental illness. Again, the National Mental Health Program is for implementing mental health. Again, it doesn't consider a special category for maternal health. And in 2014, the National Mental Health Policy is designed to reach the vulnerable population, but again, specific interventions for women in the perinatal period are scarce. So the existing programs doesn't really cover for it. And also the lack of awareness, the social stigma, and even though there are finances, more goes into research rather than the proposed the NMHP program where to reach more people, and implementation, human resource infrastructure are the challenges. So future implementation could be better implementation of the existing NMHP, so it covers it, or integration of a mental health component with the existing obstetric care. But however, it might be very taxing for the person because already there's a lot to cover, or inclusion of a separate maternal component to the NMHP. And the legislation, the 2017 Mental Health Care Act, specifically mentions child below 3 years of age shall not be separated from the mother during an inpatient care unless it's a risk to the baby. So again, the maternal and infant bonding interventions have to be made. So the mother-baby units started off in NIMHANS. This is the picture from there. So it's a 5-bedded mother-baby ward. And there are specific interventions for mother and infant bonds. And it not only educates the baby, but also the mother, spouses, family members. And there is provision for pumping the milk, storing the milk, separate space for the baby, caregivers. So and there's license with pediatricians. So it's a wholesome, holistic program that we can offer. And it's found to be impactful also. And it's said that maternal and baby units is in a low resource setting is possible, and it's associated with good clinical outcomes. There is a lot of limitations in the current research, given more focus is given for depression. There's comorbidity, which is not looked at, and long-term outcomes of the baby. There's hardly any studies to say that infant care by itself can cause some symptoms. And most importantly is confounding by indication, which means depression or the mental health illness by itself can cause some certain outcomes rather than actually the exposure of a particular drug. That is confounding by indication. And it's very hard to actually eliminate that risk in the current research. So to conclude, enlarging the focus to include not only the perinatal mental health, the pregnancy and the postpartum, but also the preconception optimization is very important. And changes in the mental health laws, obstetric care facilities, and more trained human resources are necessary. And mother-baby units for expert inpatient care of postnatal mentally ill mothers are very, very important. And other disorders, apart from depression, we have to move on to talking about anxiety, eating disorders, sleep disorders, borderline personality, because it has a huge impact in attachment of children. and including other family members, and also highlight on paternal mental health. And if we want to prevent mental illness in the future, it is time to invest in the mental health of the mothers.
Fellow in itself. So thanks Srinidhi for a wonderful presentation. So Dr. Balaji is all set for his next presentation. We have Dr. Balaji. Thank you, Srinidhi. We'll next have Dr. Balaji from Kilpack Medical College. He has finished his undergraduation from Kilpack and post-graduation from Chengalpet Medical College. He's an very good academician, had got many honors and distinctions during his undergraduate period, and has also passed out in first class in Chengalpet Medical College, won second prize in poster presentation in Ipsacon and Coorg. So for such an important topic, the next topic in Liaison Psychiatry and its current trends. So as I mentioned before, most psychiatrists are getting employed in general hospital settings nowadays, and we will have to coordinate and liaise well with the family, other department faculties, and colleagues. So,
yes, sir. Good evening, everybody. I thank IPS for giving me this opportunity to present an Enrich webinar on the topic of an overview of Liaison Psychiatry and its current. So my presentation will have the following topics. First is introduction. Next is mind-body dualism, where we will discuss about the physical and mental health and its interconnections. What is Liaison Psychiatry as such and terminologies pertaining to Liaison Psychiatry.
Dr. Balaji, we are still seeing the first slide.
Now, sir.
Can you put it in slideshow?
Yeah, sir, it's in slideshow, sir.
But we are not able to see it in slideshow. Maybe can anybody else tell whether it's in slideshow? Yeah, now things are better. I think you can better select the PPT from the slides from the left and proceed presenting.
Yes, sir. Yes, sir.
Yeah.
Yes. So next is license. What is Liaison Psychiatry as such, and terminologies pertaining to Liaison Psychiatry, and what are the importance of Liaison Psychiatry in our day-to-day practice, and what are the past trends of Liaison Psychiatry when compared to Western countries and with India, and an overall view about what are all the patients that is being referred from various departments to psychiatrists, an overview of evaluation process in Liaison Psychiatry, and what is the current trend of Liaison Psychiatry in India at present, and from here where we go to the future perspective, and finally the take-home messages. So as we all know, health is defined by WHO as health is a state of complete physical, mental, and social well-being of an individual, and it is not merely the absence of disease or infirmity. So there is no health without mental health. So this one is as we all know, there is a romanticizing relationship between the mental health and physical health. So this mental health and physical health has interconnections. As for any other relationship, it is both complex and bidirectional in nature. I'll explain how complex and bidirectional in my further slides. So when a patient harbors illness or symptoms, he goes in for lifestyle changes, and these lifestyle changes will cause stress to him, and further stress can lead to psychological disturbances, and these psychological disturbances can in turn increase the illness or symptoms of the patient. So this is how the bidirectionality between the physical and mental health exists. Next is the complex or complicated relationship between the physical and mental health is that a patient who has got a known physical illness will present to us with psychiatric presentations like delusions and hallucinations, psychiatric complications like suicide, self-harm, or delirium, or any other psychological reactions like it can be an acute stress reaction, or it can be just an adjustment issues like that. Or else the patient with a known psychiatric illness can present to a psychiatrist with a medical presentation or a medical complication. Sometimes comorbid physical and psychiatric illness can co-occur in the same patient itself. So this is how is the complex nature of physical and mental health being related to each other. So when there is a breakup of this relationship between mental health and physical health, you have this manifestation of diseases or disorders. As we all know about the Iceberg phenomenon, the tip of the iceberg denotes a clinical disease, which denotes the physical illness and the psychiatric illness that is obviously seen by the clinicians and psychiatrists. The hidden part of, or the submerged portion of the iceberg denotes the hidden psychiatric morbidity in a physical illness patient, or the hidden physical illness in a psychiatric inpatient. So some data to substantiate the hidden psychiatric morbidity in a physically ill patient from an Australian study where the prevalence of morbidity was significantly higher in medical than in surgical, which is 45 and 23 respectively in inpatient. In Indian study, the prevalence was 51%. Among the patients with both medical and psychiatric illness, the medical illness preceded psychiatric illness in 28% of the cases. Both occurred simultaneously in 31% of the cases, while 41% of the cases, the medical illness followed the psychiatric illness. So whether it is important to know the hidden part of the iceberg? Obviously, yes, because a patient receiving a physical illness but has a hidden psychiatric morbidity continues to harbor the physical illness because the psychiatric morbidity is still not being treated. So this complicates the management, which increases the symptom burden. There will be a low adherence rate to treatment. There will be impaired quality of life, leading to poorer prognosis and increased mortality. So it is essential to deliver an integrated and comprehensive mental health care that positively impacts physical health outcomes as well. So this is where the licensed psychiatry plays a crucial role and important role for us, for all of us. So moving on to licensed psychiatry, the other terminologies used for licensed psychiatry in proper or consultative psychiatry or consultation licensed psychiatry. By definition, it is a branch of psychiatry that specializes in the interface between other medical departments and psychiatry, usually taking place in a hospital or a medical setting. So it is one of the young and emerging subspecialties of general psychiatry. So why should we know about licensed psychiatry or the importance of licensed psychiatry? As I already mentioned about the psychiatric morbidity in a physically ill patient, it can be obvious or it can be hidden as well. It is a branch of psychiatry that brings medicine close to our general psychiatry. Then imparting medical education to the postgraduates or undergraduates regarding licensed psychiatry in the curriculum itself can help to deliver a comprehensive and integrated healthcare to the patients, thereby increasing the overall quality of the patients. So moving on to the history, in Western countries, Edward Billing was the first to coin licensed psychiatry. As we all know, George L. Engel was the involved in development of licensed psychiatry, who coined the term biopsychosocial model as well. The faculty of licensed psychiatry was established within the Royal College of Psychiatrists in 1997. The European Association of Consultation Licensed Psychiatry and Psychosomatics also produced a set of guidelines for training in licensed psychiatry. The American Psychiatric Association formally recognized licensed psychiatry as a subspecialty in 2004. This is with regards to Western countries. What are the past trends with regards to India is that before 1930, it was mental health hospitals or asylum settings. After that, there was establishment of general hospital psychiatric units, of which it was first established in Calcutta in 1933. Dr. Girindra Shekhar was the one who established it. Then in 1960, because of increasing resistance due to stigma and all those things, the psychiatric units liaised with the neuropsychiatric centers. So they called it as neuropsychiatric clinics. From 1970s, we have increase in general hospital psychiatric units. And now and after that in 1984, in a workshop by IJP, where it was mentioned that postgraduate training, it was pointed out that familiarity with psychosomatic medicine and licensed psychiatry is advisable for postgraduate training. So these were the past trends in India regarding licensed psychiatry. So next is certain terminologies that we have to know regarding licensed psychiatry, or first is consultation. In proper, it is actually called as consultation licensed psychiatry. First is consultation and other is liaison. Consultation, as we all know, it is the expert opinion that is being given for a patient regarding the diagnosis, treatment, and care. And liaison is linking up of many groups for a collaborative care. So these terminologies are complementary to each other. So a proper consultation is the proper interface between these three teams. One is the patient and the patient's team, the patient attenders or family members. Next is the consultee or the consultant and the therapeutic team. The licensed psychiatrist from the therapeutic team acts as an interface between all these three domains. So another terminology is the psychosomatic medicine. The psychosomatic medicine, it denotes the non-clinical part, which involves the factors like biopsychosocial factors involved in the causation and the etiopathogenesis of the disease. It is more of a theory part, whereas the practical domain is the consultation licensed psychiatry. So etiopathogenesis of the disease is dealt with psychosomatic medicine, whereas the applied part, the disease has manifested, and how you are going to diagnose, liaise, and then treat the patient is with the licensed psychiatry part. So to understand licensed psychiatry, we have many approaches, like patient-oriented approach, where the patient is the main focus. Patient's diagnosis and treatment is the main focus. You can also denote patient's personality, patient's perceiving of the illness and reaction to the illness is also approached in this. Next is crisis-oriented, where the patient's problems, like what are the patient undergoing stressors and coping up strategies for those problems are under focus, and immediate therapeutic interventions can be suggested in crisis-oriented approach. Then consultee-oriented is the main focus, where the consultant's expectations about the future treatment and progression of the disease is the main focus. Situation-oriented is interpersonal interaction of all the members of the clinical team is the focus. And next is the expanded psychiatric-oriented approach. It is a wholesome focus where you have patient family members, clinicians, consultant, mental health professionals, psychiatrists, other non-clinical staff members, all those things. But in this also, the patient is the main focus. In India, we follow this expanded psychiatric-oriented approach, where patient being the main focus, and we include all the other members as a wholesome thing. Next, with regards to model of consultation licensed psychiatry, you have 5 models. One is consultation model, where it is a traditional model where the patient is the main focus. Next is the liaison model, where the consulting physician is the main focus. Bridge model, where the psychiatrist acts as a teaching role to the primary care physicians. Next is the hybrid model, where psychiatrist acts as a part of the multidisciplinary team involved, and autonomous, where the psychiatrist has an independent role. In India, we follow predominantly liaison model and also sometimes hybrid model as well. So as I already mentioned, what are all the patients that is being referred to psychiatry from other departments? In an umbrella will be the physically ill patient with psychiatric presentation and psychiatric ill patient with medical presentation or complication. Other patients referred are for capacity assessment, suicide and self-harm, medically unexplained symptoms, and 50-50 for the diagnosis. Like for example, dementia patient where 50% diagnosis and treatment and management is from physicians or neurology, and the 50% it will be from our side, like detecting the behavioral and psychological symptoms of dementia and taking care of those symptoms would be from our side. So these are the patient in an umbrella or a nutshell that is being referred to us. Now I'll tell you about the overview about each medicine, each specialty department, and what are the cases that is being referred. So with regards to medicine and its specialties, most commonly delirium is being referred to psychiatry department because the symptoms are alarming and it is a medical emergency. So these are the risk factors which I mentioned in the slide, like patient age greater than 65 years will have a risk of developing of delirium to 30 to 40%, and patient in ICU will have risk of developing delirium of 30 to 90%. Next is suicide attempt or self-harm patient from a study from South India, which includes there will be no diagnosis for 41% of the patient. Predominantly, it will be impulsive suicide attempt. And if at all you have a psychiatric diagnosis, it will be major depressive disorder, followed by alcohol dependence, adjustment, and dysthymia, and all the other disorders following those things. Next, other patient referred from medicine or for depression, agitation. Agitation can be due to some cognitive disorder or associated with withdrawal from drugs, or it can be secondarily due to some acute psychotic symptom for the patient. Next is hallucinations. It can be secondarily due to substance use or substance withdrawal, delirium in case of visual hallucinations, and psychosis, and patients in ICU setup because of decreased sensory modality or sensory depravement, you can present with hallucinations. Then sleep-wake disorders, you can have referral. for substance use disorders, and chronic pain patients can be referred to psychiatric department for sleep disorders and adjustment issues or any stress reactions. And diabetic patients, the psychiatric comorbidity that is being referred predominantly is for depression and anxiety symptoms. And apart from that, you have the somatoform symptoms because of the peripheral neuropathic pain that the patient tells to the clinician. This anxiety spectrum disorder in diabetic patient will be difficult to diagnose because there will be hyperglycemia and hypoglycemia, where you have sympathetic overstimulation, which will simulate all the symptoms of anxiety like tremors, palpitations. So it will be difficult for us to diagnose as well. With regards to thyroid disorders, hypothyroidism and hyperthyroidism, as we all know, cognitive deficits, depression, and anxiety symptoms, we get referral for thyroid disorder patients. With regards to stroke, the most common referral which we get is for post-stroke depression and for apathy. With regards to ischemic heart disease patient, pre-existing depressive symptoms, 20% report to develop CAD symptom burden. With pre-existing CAD, risk of death of patients with depression is 3 to 4 folds higher in CAD patients than in non-depressed patients. So patients can also be referred for phobic anxiety, panic, and hospitalized patients. Next, for tuberculosis, referral from chest physician department for starting or fitness to start any multi-drug regimen, where we have to screen for depression or any stress reactions to the patient. Next is chronic kidney disease patient, where the patient is being referred for fitness to surgery for transplant, where cognitive impairment, depression, and anxiety has to be taken into consideration. Then for epilepsy patients can be referred from neurologist if the patient has got any depressive symptoms or increased suicidal tendencies, and for anxiety. This headache patients, we commonly get referral from neurology department. Apart from the dysthymia, depression, and anxiety, this OCD symptoms has to be ruled out in this patient because there is a prevalence of 10.8% of OCD because of the repetitive thoughts which causing headache and sleep disturbances to the patient. And finally, a note on medically unexplained symptom with regards to medical specialties. It is present when psychological or emotional distress is manifested in the form of physical symptoms that are otherwise medically explained. So it is otherwise called as somatic symptom disorder. You can get symptoms from all the systems like pain, fatigue, GI symptoms, cardiovascular symptoms, neurological or reproductive organ symptoms. Here, anxiety is the hidden part. Predominant patient present to you with anxiety or with depressive symptoms. From surgery and allied departments, we get referrals for substance use disorders, post-operative delirium, post-traumatic brain injury, where it is a sequel starting with apathy, depression, and going in for psychosis. In plastic surgery department for body dysmorphic disorder. Then for psycho-oncology department, where you get referral for adjustment issues and adjustment disorder. And predominantly you get this for claustrophobia and needle phobia and anticipatory vomiting secondary to radiotherapy and chemotherapeutic agents that is being given to the patient. As Madam very well explained about the perinatal psychiatry, we get referral in all stages of pregnancy for depression. It is to be noted 70% of the women report some negative symptoms during pregnancy, of which like 13 to 70% qualify for major clinical depression. So depression, anxiety, we get referral. And this OC symptoms or OCD, 39% of the participants reported their OCD began during a pregnancy. So for this also we get referral. And post-traumatic stress disorder, because of the early pregnancy loss, we get referral. Then from dermatology department, we get referral, and hidden thing apart from all the depression and anxiety, personality disorders has to be ruled out. From pediatric department, we get referral for developmental delay, dysmorphic phases, or any genetic syndromes that is being referred to us for further evaluation. And a child with poor scholastic performances, and this sudden drop of scholastic performances, like a child was performing well and there is sudden drop, gives a hint for childhood depression. So we get referral for that also. And behavioral problems in the form of self-injurious behavior. It can be internalizing or externalizing behaviors. We also get referral from ophthalmic department for black patch delirium, ENT for giddiness and all those things and many somatic complaints, and from rheumatology department for chronic fibromyalgia or chronic pain syndromes. So after you get the referral, there are certain steps to be followed for effective liaison psychiatry. So first step is talk. Talk with the patient family members, treating physician, treating clinicians, staff nurses, any healthcare professional that is available with the patient. So why should you talk with the patient is that to clarify the reason for referral, because that is, if you clarify the reason for referral only, from that is where your further history taking and examination should proceed on. So first initially talk with the patient and then clarify the reason for referral with the clinician and the family members or whomsoever is concerned with the patient, clarify it.
Doctor, 5 minutes.
Yes, sir. Next is estimate the level of urgency. So this is actually, we call it as triage. So which patient to be attended first or as an emergency. So these patients you can take into consideration like harm to self, harm to others, and physically debilitating condition patients because of an active psychiatric illness. So this can be attended first. Then you can go in for attending other patients. So estimating the level of urgency. Next is reviews charts and data. So this is a very important step. This will take around only 2 to 3 minutes to just scan the entire case sheet. So you can scan it from the page 1 to till date. So you can see the investigations, BDBP chart, IO chart, any missing investigations, any discrepancies in investigations, what was the physical diagnosis or clinical diagnosis made in the medical side, and was there any change of diagnosis? When was the psychiatric presentation started? What was the drug that is being given initially? Was there any change of drugs? Is there any temporal relationship between the change of drugs with the psychiatric presentation that has been started? So all these gives you a hint when you review all these charts and data thoroughly. This will take just around 2 to 3 minutes to scan the entire case sheet. And I advise everybody to follow this scanning of case sheet from page 1. Next is history taking. So you actually, history taking is normally from a psychiatric perspective. So why the patient has been referred, and for the pertaining psychiatric presentation, you can probe your history taking to the family members and do a mental state examination with the patient and find out if there is any delusions or hallucinations or whatsoever phenomenology you find. Next, documentation. Documentation is very essential in licensed psychiatry. If you go for a call over, you have to start with seen by who has seen the patient, seen by assistant psychiatry or seen by PG, with the date and time being documented, and kindly thank the department for referral, and then going for writing the socio-demographic details, reason for referral, and then psychiatric presentation, a brief psychiatric history of presenting illness with very simple words, not using any jargons, and then going for writing mental state examination. And if you are going to advise any investigations, you can write it in the site as well as your treatment. So documentation is very essential. Then if you are, then you can make a clinical diagnosis or provisional diagnosis. If you are not sure about the diagnosis, just make a differential diagnosis, or you can just make a terminology like psychosis for evaluation, behavioral disturbances for evaluation, altered sensorium for evaluation, and reserve your diagnosis with the future visits. Next, as I already told, you can write the investigations which you want to do, and you can also write any psychometry rating scales that you want to do for the patient in future visits once all these psychiatric presentations settles. Then medication, this should be very important because you have to use very simple drugs. There is a dictum like start low and go slow. Do not experiment more with the drugs in medically ill patient. So be simple and do not use polypharmacy. And also you have to have a thought about the previous drug interactions and the drug interactions that is being that can interact with the medical drugs or surgical drugs, and also the any renal impairment, hepatic impairment, or hepatic decompensation. All these things has to be taken into consideration while you write the prescription for the patient. And finally, the follow-up. Follow-up for acutely ill patients, you can do a daily follow-up, and for other patients, once in 3 days follow-up will be fine. And finally, this takeover part is critical, and it is also like critical. So you can, please do not hesitate to take over the patient to your side, but with proper documentation and all being done. Once the patient is physically stable, and write it, get a documentation from the consulting physician, and then take over the patient for your psychiatric care. Now, last part, just I'm running out of time. So with current trends in India, this is from a study by Sandeep Grover, sir. The type of licensed psychiatry, predominantly 76% is on call, where the psychiatrist goes to the particular ward and do the licensed psychiatry services. And the junior resident comes in contact as the first line person in contact in predominant of the cases, followed by senior resident and then the faculty member. And for daily, we receive around 7.33 on an average from 0 to 20 calls per day. And predominant diagnoses were delirium, followed by substance use, then self-harm, depression, somatoform, psychosis, dissociative disorders, dementia, finally sexual issues. So the training with regard to licensed psychiatry, exclusively licensed psychiatry is present. Training is present in only 29% of the participants who attended the survey, and the duration was 2 months. And the research projects and dissertation were 1 in number for the person who attended the survey in that study. So the concluding thing is that there is a need to improve licensed psychiatry services, training program, and research in various medical institutes to provide a good mental health care to medically ill patients. So steps to improve licensed psychiatry, future perspective, develop workforce and expertise in licensed psychiatry across the country, start training programs in licensed psychiatry, sensitize physicians and surgeons regarding the role of psychological factors in causation of disorders, enhance the licensed psychiatry clinical services, training, research in the country. Training programs must integrate care of major psychiatric disorder with common mental disorders, so that providing a holistic view. Training programs for undergraduates and postgraduates should be essential to know about the mind-body interaction. Finally, take-home messages. There is no physical health without mental health. This licensed psychiatry has brought psychiatry very close to advances in medicine. Licensed psychiatry have adequate, psychiatrists should have adequate knowledge of mental and physical illness, as well as how they affect each other. They should also know how various drugs and diseases interact with psychotropics, and with special regards to their safety. Proper documentation is necessary. Licensed psychiatrists should look at complete picture while providing services, and licensed psychiatry as a separate subspecialty and adequate training programs for UGs and PGs can take licensed psychiatry to a long way. Thank you.
Thank you, Balaji. That was a wonderful talk. I mean, many a times we get lectures which is totally sort of theory oriented, or lectures which are more practical and day-to-day pragmatic lectures. But yours was a wonderful lecture in the initial part, covering the basics, foundation stone of consultation license psychiatry, from explaining the terminologies, a brief history. Then gradually you moved on to the main thing you discussed about the similarities of the symptoms between the medical illnesses and the psychiatric complaints which we are going to diagnose, and the skill that is required by a mental health professional in understanding the cause for it. Then gradually the individual issues, and at last the a thing which the trainees will be helped upon is the a simple flow chart of how they can approach. Thanks a lot, Balaji. It was a very good comprehensive presentation. I would want to say that both these topics are individual postdoctoral fellowship programs in NIMHANS for a year. So I really congratulate both the speakers for having tried to cover it comprehensively in a brief half-an-hour talk with me behind their backs. So thanks a lot. And now it is open to question and answer session. Have your questions?
Good evening, sir.
Yeah.
Good evening, sir. This is Dr. Manjula. I have a question for Dr. Balaji. Sir, you said consultant licensed psychiatry is for general hospital setup. What if it is a clinic or a private setup where you do not have any clinic, where we liaison with the other doctors as well? Isn't it called as a licensed psychiatry?
Yes, ma'am. I have covered predominantly for the general hospital setting or a tertiary care center. But liaison itself, it means like you collaborate your things to other persons. So you intermediate or you mediate information to other persons. You have to develop contacts with other fields of medicine, surgery, or whatsoever, cardiology, and then do it in our private setup or in a clinic setup, ma'am. So that would be my suggestion for clinicians who are practicing outside, because we can't do things like independently in all times. There are times which we have to liaise with certain peoples like medicine physicians or opinion for any ECG, for any sort of thing like that. So that time, developing contacts in that field of specialty will help us to gain much more care for the patients, ma'am.
Thank you, sir. Thank you so much.
Thank you, ma'am. Thank you.
Thank you, Dr. Manjula. Any other questions?
Good evening, sir.
Yes.
Dr. Karthik Dev,
Yes.
both the presentations are very useful and wonderful. My question to first presenter, Dr. Srinidhi, madam. In Tamil Nadu, we have started that integrated maternal mental health program recently, and we have trained obstetricians, medical officers at the PHC level, and also staff nurses at the PHC level to give specific focus on mental illness among pregnant mothers as well as postpartum related issues like postpartum depression and psychosis. And this is going on, and training is being conducted as integrated one. My question is regarding the Edinburgh scale. The Tamil tool is user friendly for the field worker to apply. Is there any other suggestion?
Yes,
What
sir.
is the role of PHQ Tamil version?
The role,
yeah.
Yes, sir. So for the field workers, generally we use more of PHQ and GAD scales rather than the Edinburgh, because the translation is not always culturally correct, and it doesn't use the exact words are not actually translated.
Exactly.
So just in general, using for large population studies, the PHQ and the GAD scales would be better rather than Edinburgh postnatal depression scale, sir.
Yes, madam. That's what, because as you said, the Edinburgh is not usable. Culturally, it is not appropriate and difficult to use it.
Yes,
and, yes, madam. Thank you.
And training, it's good that we've trained antenatal care people on this, sir. But just that they already have too much of burden to assess. I mean, giving supplements and so many other things. So for them, in the long term, to continue doing mental health care work along with the physical health that they cater to might become very challenging. So we will have to look at whether in other areas, how do we bring in this specifier and how do we actually integrate this in the long run?
Yes, madam. Actually, we cannot create a separate vertical given the level of stigma and other issues in the community, even among the medical and paramedical people. So the level of sensitization we hope will take forward this, because we cannot create a separate workforce and public will not be receptive to that, given the cultural context of Indian situation, wherein the woman has to go and live with the in-laws. We have discussed and decided to implement this one through the regular ANC program, and so that even we don't use the word mental health questionnaire or something like that. We have wellness questionnaire, wellness sessions, and the marida use pandrom. So the integration of this into the CMOM program seems to be an appropriate one, considering not only the financial or logistics, considering the level of stigma. This seems to be the way forward as of now. We have to wait and see. Yeah.
Wonderful. Dr. Karthik, thanks a lot for bringing up the point. I think many of us are battling with stigma in the field of mental health and psychiatry. These two fields, especially consultation, liaison, psychiatry, is an area where if we maintain a correct attitude with our fellow doctors, general medicine doctors, physicians, and other specialists, they will be our voice and they will sort of help a patient get better. So this is one very important way in which we can try to reduce the stigma of the psychiatric illness through consultation, liaison, psychiatry.
Yes, sir.
They also do a lot of things. கவுன்சிலிங்க்கு தான் பேஷண்ட் அனுப்புறோம், அங்க போய் பாருங்க, அவங்க வந்து கொஞ்சம் ரிலாக்ஸா எப்படி இருக்கிறதுன்னு சொல்லி தருவாங்க. So they also know how to help us, just that we should not go in loggerheads with them. மெனி
ஆமா.
டைம்ஸ் அது ஒரு attitude வந்து ஒரு ஈகோ கிளாஷ் மாதிரிலாம் நிறைய டைம் வந்துருது இந்த ஜெனரல் ஹாஸ்பிட்டல் செட்டிங்ல. இது வந்து இவங்களுக்கு சைக்காட்ரி பத்தி அவ்வளவு தெரியல, இவங்களுக்கு ஜெனரல் மெடிசன் வந்து அவங்களுக்கு ஸோ இதெல்லாம் இல்லாம ஒரு ஈச் அதருக்கு நம்ம ஒரு சினர்ஜிஸ்டிக்கா நம்ம அவங்களுக்கு ஒரு விஷயம் சொல்ற மாதிரி அவங்க நம்மளுக்கு சொல்ற மாதிரி அட் லாஸ்ட் பெனிஃபிட்டிங் பர்சன் பேஷண்ட் அண்ட் ஃபேமிலின்ற மாதிரி ஒரு கம்பைண்டா போனோம்னா தென் ஷுவர்லி இட் வில் பி குட் ஃபார் ஃபியூச்சர் ஆஃப் சைக்கியாட்ரி அண்ட் ரெடியூஸ் இட் ஸ்டிக்மா.
தட்ஸ் வாட் கன்சல்டேஷன். ஆமாங்க சார். ஏன்னா நல்ல ரெஸ்பான்ஸ் அந்த மிட் லெவல் ஹெல்த் ப்ரொவைடர்ஸ், விஹெச்என்ஸ், மெடிக்கல் ஆஃபீஸர்ஸ் கிட்ட இருந்து தேர் இஸ் a வெரி குட் ரெஸ்பான்ஸ். அதே மாதிரி அவங்க தான் அக்சசபிளாகவும் இருக்காங்க. given the limited number of professionals available and the public approach, attitude towards psychiatrists. நீங்க சொன்ன மாதிரி our attitude towards other specialists also, we have to somewhat we should become more accommodative and so that the benefit of the science goes to the public who are in need. Yeah.
Keep up your great work, Dr. Karthik. Thank you.
And definitely good.
Any further questions from trainees? Where any questions?
Dr. Srinidhi,
Sir?
You said that in Kerala and Karnataka they are implementing this perinatal psychiatry. Whether they are implementing through the national mental health program or with the health system there, general health system, how they are implementing both the
general health system, sir. So in the general antenatal card, they have a question on a question about their mental health, sir.
It's a Thai card, no?
Yes, that antenatal card that usually they have. So they're about the trimesters, the supplements that they have to take, and that has an questions on antenatal. That has a check on antenatal, the mental health also, sir.
They are having any screening questionnaire or something? How they are doing it?
No, sir. That is to screen. Just ask a question on mental health. So, is there some emotional issues that that they have been facing? So it's not very detailed, sir.
If they said yes, then what they will do? How they will do intervention? They refer to a psychiatrist or they themselves will counsel?
I mean, I'm not very sure, sir, but the system is not in place. So that's why I brought up, even if we screen, what are we going to do with them? So how are we going to take on, I think as a first step, they've started including, but then what do we do with them is the next steps that we have to further see, sir.
In Goa, actually, I was last time I went to a conference in Goa, it's South Zone. There, that Vikram Patel sir has implemented one project with a psychiatrist there. They are doing a big project there. They will have they trained a toy, and the toy they will have a set of questionnaire. They will screen it. Then they have given a training for a block level also. Block level training given to the doctors. And the 3 level of that consultation was there, and finally they may go to they will refer to a psychiatrist. I think a big project is going on in Goa. 3 months back, I went to the Goa state president was in charge of that. This mother baby, this perinatal psychiatry. A big project is going.
Okay, sir.
Probably once it has been successful, the Goa government is planning to implement it in a state level.
Thank you, sir.
Yes, sir.
One other area is gender dissatisfaction post delivery. It's almost like an exam many women face. After the exam, if the child is of the desired gender or not, that determines family support, family's happiness, the patient's bonding with the child's care by the family. So gender
and especially the second girl child, sir.
Yes. One other thing coming up nowadays is I need a girl child. There are boys, I need a girl child. So there is also another set of people also I am facing. That few people want girl children. So that the gender dissatisfaction is one thing, which is also. Please, any other comments from seniors?
So 1 minute, Kailash, regarding
Yes,
this gender discrimination. We too had, as she said, it was the second girl child. And now I have met, yeah, as you said, the first is the boy. They want a girl. The second child was a boy. She didn't even have that bonding towards that boy kid. So that also is happening nowadays. One thing. And second, as Dr. Karthik Devanakam said, in Makalai Thedi Maruthuvathila, they have included some questions regarding the perinatal health. So what we are doing in Chengalpet, what we had been doing is how the mother feels, and it is about the pregnancy, right? Is she having some good sleep? Is she able to enjoy it and any other relationship issues she has with the husband? And regarding this, if there is any problem, anything, they are referred to the psychiatry department or not to the psychiatry department. They are there in the OG because the stigma plays a very important role. They are in the OG department, and we'll have to address the 10 or 15 people we collect, and then we do it. Okay, regarding those issues. And it is like a group therapy also. Right? Among them, what they face, any issues, relationship issues, it might be economic issues, it might be fear of childbirth, anything of that sort. So we have encouraged, and that is also is booming up. So every 2 days we had on Tuesdays and Saturdays. So that when they have some issues regarding anything, that is brought to the focus. Okay, right? Whether it could be a psychological role plays a very important, psychological part plays a very important role. That also we started seeing. And it is only sometimes the social support system is lacking. That we have to provide that. Or it is sometimes the medication. Not always the medication. Okay, right? That is being addressed. That is what. In the Makalai Thedi Maruthuvathili, they have started implementing this a bit. So that is during the pregnancy. That too during the pregnancy period.
Thank you, ma'am.
Karthik, Makalai Thedi Maruthu, because Roshan was very particular about that.
Yes, madam.
Questions we added. That's what. Are you enjoying the pregnancy? Pregnant, how do you feel? Okay, right? Is your sleep is good? Is your appetite is good? Okay. You have any issues? And the madri, general. If they bring out, then we are addressing it.
Yes, madam. To add on to that, now we have included mentor psychiatrists for every block.
Yeah. Okay.
The doctor psychiatrists in the medical college as well as in the DMH program or any other psychiatrists in the government, they are allotted one block so that they will be available for the medical officers and the field workers in the field. Any clarification they can discuss over phone and give basic something like a brief intervention and refer if needed. This is one. And also we have included in the Lakshya Keshi the PhD questionnaire because initially it was we discussed about Edinburgh, but PSQ is there, and we have given the training for PhD medical officers also. This kind of developments is going on. Hope will improve in future, madam. We have to bring down the
PHQ2 is there, sir. PHQ2.
Yeah, PHQ2 is there. Yes.
2, 4. That also is good work.
ஒரு மூடு ஒரு இன்ட்ரெஸ்ட் அவ்வளவுதான் அதுல.
ஆமா, நான் என்ன சொல்லி கொடுத்துட்டு பேஸ்ட் ஆன் த இம்ப்ளிமெண்டேஷன் we can தேவைன்னா HSC level 2க்கு போலாம் அப்படின்ற மாதிரிலாம் வச்சிருக்கோம். But it's a good time we are talking about these things, and the government is also giving importance to these things, sir. At a higher level, it is being reviewed. Yeah.
Yes, another one doubt I have, whether consultation liaison psychiatry is the same as psychosomatic, because psychosomatic medicine also is there, right? Because we have whether it is the overlapping one or it is the same.
Actually, psychosomatic medicine deals with the factors causing the disease process. It can be the biological, psychological, social factors causing the which are leading for the etiopathogenesis for the disease. And this consultation liaison psychiatry is the apply down of the psychosomatic medicine. So
Balaji soltar, adu theory, idu practical.
Okay. It's really confusing sometimes.
Yes.
I can tell you very frankly, when you say psychosomatic disorders, that the psychological part play a very important role. Sometimes it is what you call that as medicalization of psychiatry and psychogenesis of medical illness.
Yes,
Both, right? Psychogenesis of medical illness is psychosomatic.
Another one small question. இப்போ குழந்தை பிறக்கிறது வரையிலும் மதருக்கு ரொம்ப இம்பார்ட்டன்ஸ் கொடுப்பாங்க. The moment baby delivers, மதருக்கு பெருசா இம்பார்ட்டன்ஸ் இருக்காது. How the mothers feel, அதை எப்படி நீங்க ஹேண்டில் பண்றீங்க? What is your suggestion? மேடம்
எதுப்பா இல்லப்பா
Srinidhi madam.
கண்டிப்பா இல்ல mothers will be given the attention. Why not? Babies will be given attention. That is something different. Mother நல்லா பாத்துப்பாங்கப்பா. That too first 3 months. After that only it becomes really a problem.
மதர் சொல்லிருக்காங்க. அதான் அவங்க ஸ்பீக்கர்ட்டையும் கேக்குறேன் அவங்க எக்ஸ்பீரியன்ஸ் என்னன்னு. இப்ப டெலிவரி ஆகிறவங்களும் ஒரு கவனம் இருக்கும். ஆஃப்டர் டெலிவரி அவங்கள ஒரு லெட் டவுன் மாதிரி தான் நிறைய மதர்ஸ் எக்ஸ்பிரஸ் பண்றாங்க. சிண்ட்ரோம்லாம் நம்ம முடியாது. பட் தீஸ் ஆர் issues of concern for the mothers, madam. அதனாலதான் கேட்டேன்.
இல்லப்பா எனக்கு தெரிஞ்சு பாத்துப்பாங்க, நல்லாவே பாத்துப்பாங்க, நல்லா சுட சுட சாப்பாடு கொடுப்பாங்க எனக்கு தெரிஞ்சு. Like after delivery I can tell you specific foods that
Specific
are
foods
being
for
provided.
increasing lactation.
I can tell you, and the adequate rest is being provided for at least first 2 to 3 months. After that only it becomes a routine, like she has to take care everything.
மதர்ஸ் என்ன சொல்றாங்கன்னா அது எல்லாமே குழந்தைக்காக தான். டெலிவரி வரல ஓகே என்ன கவனிச்சாங்க, குழந்தை உள்ள இருந்தது. ஆஃப்டர் டெலிவரி குழந்தைக்காக தான் என்ன கவனிக்கிறத விட்டுட்டாங்க, இம்பார்ட்டன்ஸ் குறைஞ்சிருச்சுங்கிற மாதிரி நிறைய மதர்ஸ் ஃபீல் பண்றாங்க.
So that is true. So even last week when I saw somebody, she said, இப்போ எனக்கு ஸ்பெசிபிக் சாப்பாடு கொடுக்குறாங்க ஏன்னா குழந்தைக்கு அந்த பாலுக்காக கொடுக்குறாங்க. So it's not for me அப்படிங்கிற மாதிரி. There are a lot of mothers. Even last week I had a mother who said that. So
அதை ஹேண்டில் பண்ணீங்க சொல்லுங்க.
என்னங்க சார்?
How are you handling those?
So because we counsel the family also. So they usually அவங்க வந்து first அந்த பேபியோட immunizationக்கு இல்ல that they bring the family also. So it's either the mother will be there or the husband will be there. So when we counsel them, and they also become aware of that particular woman is going through such feelings, and அவங்க தெரிஞ்சதுக்கு அப்புறம் then it doesn't really strike them.
ஆமா, we have to sensitize them. Not only consultation மட்டும் இல்லாம பொதுவெளியிலயும் we have to discuss these issues and sensitize the public in general also.
அந்த ப்ளூஸ் அப்பதான் டிப்ரெஷனா மாறிடாது. ப்ளூலயே நிக்கும்.
Yeah.
Anything else? Any other comments from seniors?
Sir, good evening, sir. This is Dr. Nasrin. Sir, I would like to answer the question raised by Dr. Karthik, sir. So, இப்போ நான் வந்துட்டு non-service PG psychiatrist practicing at PHC, sir. So, every Tuesday we have a antenatal day. So, இந்த importance வந்து எனக்கு தெரியறதுனால what I do is to avoid that மதர்ஸ்க்கான இம்பார்ட்டன்ஸ் குறையறதுனாலயோ இல்ல ஜெண்டர் டிசாட்டிஸ்பாக்சன் வந்துரும் அப்படிங்கறதுனாலயோ we sensitize the family on every visit, sir. Every visit I see the patient with either the husband or the in-laws or the attender who is taking the patient to the visit. So on the last trimester appo vanditte we give repeated visit. If I feel that somehow the patient's mental status is disturbed appadina, I give repeated visits for that patient, and I also can capture some of the fears of the patient. Either அதுக்கான காஸ் வந்து ஒன்னு ஃபேமிலி மெம்பர்ஸா இருப்பாங்க இல்ல சுத்தி இருக்கிற தேர் ரிலேட்டிவ்ஸா இருப்பாங்க. பிகாஸ் ஆஃப் த பேபியோட ஜெண்டரை வச்சோ ஆர் த எக்ஸ்பெக்டேஷன்ஸ் தே give on the mother for the baby, அது வந்துட்டு ஒரு certain anxiety issues வந்து இருக்கு சார். this 1 year நான் PHC-ல பாக்குற வரைக்கும். So அத alleviate பண்றது வந்துட்டு when we repeatedly say about the status of the mother that and ANC case to the family members, they understand the importance of treating the mother well. So adula irundhu vandu the approach of the family members towards that pregnant women is changing அப்படிங்கிறது my observation, sir. I haven't done a detailed study, but my observation is post delivery their care towards that mother is increasing if we sensitize them during the antenatal period. And the ஒரு visit அப்பையும் அந்த family membersக்கு when we explain the status, how is the baby, how is the patient, or how is the report, இத வரைக்கும் வந்துட்டு அந்த family membersக்கும் நம்ம தெளிவா explain பண்றப்போ அந்த மதருக்கு கொடுக்கிற கேர் வந்து இம்ப்ரூவ் ஆகுது சார்.
Definitely, yes, you are correct.
Thanks a lot.
நீங்க அப்படியே உங்க பிஎஸ்சியோட நிறுத்தாம அந்த பிளாக்குக்கே நீங்க வந்து அங்க இருந்து கிளம்பும் போது எல்லாரையும் குட்டி சைக்காட்ரிஸ்டா மாத்திரணும் டாக்டர்.
Sure,
Thank
sir.
I have one question to Srinidhi. Your comments on ECT in pregnancy, and if seniors are there, has anybody given ECT? I know it's safe. What is your comment on ECT in pregnancy, and anybody has given ECT in pregnancy, seniors? Yeah.
Kailash, in Sneh Hospital, my hospital is actually, my wife is a gynecologist.
Oh, super, sir.
All is fully dedicated only for you do cesarean and everything like that. My wife is also a mentor. I was talking about this. We are going to speak on the topic perinatal psychiatry. She was very happy. Actually, the Kathi Devan சொன்னமாரி எல்லா blockல there is a psychiatrist visiting all the block. So நிறைய psychiatric drugs இருக்கு. மத்தபடி இவங்களே ஐடென்டிஃபை பண்ணி சில கேசஸ்லாம் நிறைய பேருக்கு நாங்க வாரத்துல அட்லீஸ்ட் மந்த்லி ஒரு 2-3 கேசஸ் வந்து மெயினா அனுப்புறாங்க. இவங்க வந்து ஏன்னா மெண்டரோஜில வந்து அவங்க வந்து நிறைய இந்த அதர் தான் பிசிக்கல் இந்த எலிமெண்டோட சைக்கலாஜிக்கல் இஷ்யூ தேர் ஆஸ்கிங். சில இதை வந்து ரெஃபர் பண்ணி இந்த மாதிரி நீங்க வந்து உங்க பிளாக்குக்கு, ஏன்னா எப்படி தமிழ்நாட்டில் வந்து நல்ல சைக்காட்ரிஸ்ட் வந்து நிறைய எல்லா பிளாக் திருநெல்வேலியில் ஒரு 5 பிளாக்னா 5 பிளாக்ல எவ்ரி மந்த் சைக்காட்ரிஸ்ட் போறாங்க. ஸோ அதுக்கெல்லாம் ரெஃபர் பண்றாங்க. அதுதான் ரிகார்டிங் இசிடியில வந்து ஐ யூஸ் டு கிவ் லாட் ஆஃப் இசிடிஸ் இன் அவர் ஸ்னேக் ஹாஸ்பிட்டல். டெய்லி யூஸ் டு கிவ் 15 மினிமம் 15 இசிடி கொடுப்போம். ECT does wonder, especially for a postpartum period. Even before, நாங்க வந்து ஒரு 7 months amenorrhea also. 7 pregnant lady, a severe manic episode, we given all the drugs, then we gave an ECT for the lady. Because we have a good gynecologist setup, so we had a license with the pediatrician also. And sometimes when you give ECT, a small amount of oxytocin will be secreted and that may induce labor. So it will be very cautious. We give ECT up to 8 months வரைக்கும் நாங்க கொடுத்துருக்கோம். But we have to take a certain procedure. We have to give glycopyrrolate. We have to monitor the fetal, the cardiac monitor. We have a fetal cardiac monitor in the hospital. We all do that. After pregnancy also, if வந்து postpartum psychosis, postpartum depression, அப்புறம் வந்து postpartum psychosis also, the people does wonder with ECTs. I think it's one of the best option. நிறைய பேர் ட்ரக் கொடுத்த உடனே then you have to give high acute வந்து always the patient need a high dose of antipsychotic or antidepressant. Somehow it may have execute with the meal. ரொம்ப இது பண்ணி ரொம்ப worry பண்ணுவாங்க, நிறைய மாத்திரை கொடுத்துமே அப்படின்னா baby also you have to monitor. So அதனால என்ன பண்ணா ECT is the best option. It's a wonderful thing. I think it's a fast recovery occur with ECT than the drugs. I think this option we can
Thank you, sir. Like for example, this was the teaching in Enhance that ECT is safe in pregnancy. It has more benefit than harm.
I have given almost 100 pregnant ladies up to 7 months amenorrhea. We given ECTs. Postpartum also is very delivery actually பிரச்சனையே. ஆனா வந்து நான் இதுல சிசேரியன் ஆன ஒரு 6th day I gave ECT for one lady. She was developed severe catatonic symptoms, refused food, not sleeping, ரொம்ப ரெஸ்ட்லெஸ்ஸா இருந்துச்சு. ட்ரக் எல்லாம் கொடுத்தா எந்த ட்ரக்கும் சாப்பிடாது. தென் வந்து இன்டேக்னாலும் நம்ம ஐ ஃபீட்ஸ் போட்டாலும் எல்லாம் கையெல்லாம் கட்டி கேபான் போட்டு தான் போடணும். தென் பெட்டர் ஆப்ஷன் we have ECTs.
சார் இப்போ பிரெக்னன்சில இருக்காங்கன்னா அப்ப நம்ம லேபர் இன்டியூஸ் ஆயிடலாம், இல்ல அத மாதிரி எதுக்காவது தனியா கன்சென்ட் வாங்க வேண்டியதா இருக்குமா சார்? அடிஷனல் கன்சென்ட்
ஆக்சுவலி அப் டு 6 months ஒன்னும் இஷ்யூ கிடையாது. After 6 months அப்புறம் there is a literature says that we have to anticipate. இது வரைக்கும் நானதில்லை, நான் 8th month வரைக்கும் கொடுத்துருக்கேன். ஆக்சுவலி அந்த லேடி வந்து ரொம்ப பயங்கரமா இருக்கும். அது வந்து என்னன்னா டக்குன்னு கீழே விழுந்துரும், வயலான மேனிக் பேஷன் ஆக்சுவலா. அப்போ பண்ண 6 months அப்புறம் எல்லாமே we get a consent, written consent எழுதுவோம். We tell the risk that risk benefit சொல்லிடுவோம். ஸோ என்ன பெனிஃபிட் இருக்கு, என்ன ரிஸ்க் இருக்கு அப்படிங்கிறத சொல்லிக்குவோம். ஏன்னா நிறைய பென்சோடைஸ்பின் ஆல்சோ வி கான் கிவ் த லாங் டர்ம் கொடுத்தானா பென்சோடைஸ்பின் சைல்ட் கேன் டெவலப் கிளப்ட் பேலட் கிளப்ட் அந்த இதெல்லாம் நிறைய காம்ப்ளிகேஷன்ஸ்லாம் இருக்கும் இல்லையா. ஸோ சரி நீங்க மூட் ஸ்டிமுலேஷன் நிறைய கொடுக்கும், அதர் தான் லித்தியம் மற்ற எதுவும் கொடுக்க முடியாது உங்களுக்கு வந்து. இப்போ இது சோடியம் ஆல்பரேட்டோ அதெல்லாம் நீங்க கொடுக்க முடியாது, ஏன்னா லாட் ஆஃப் ப்ராப்ளம் இருக்கும். Then we explain and usually they accept. நான் ஜெனரலா நம்ம கொடுக்குறோம் அட்லீஸ்ட் மந்த்லி ஏதாவது ஒரு 2 போஸ்ட்நேட்டல் மதர் நம்ம ஹாஸ்பிட்டல் எவ்வளவு கொடுத்துருவோம். We enter referral also. I think is my personal experience is it is very very safe. ஒன்னா பல்கா கொடுக்கல வெரி ரொம்ப சீப்பரா இருக்கும். நான் தனியா கொடுத்தேன்னா இட் மேபி காஸ்ட்லியர், மேபி ஒரு 6,000 7,000 சென்னை மாதிரி சிட்டில இருக்கும். பட் ஐ திங்க் ரிஸ்க் பெனிஃபிட்டா பார்க்கும்போது ஈஸி இஸ் த பெஸ்ட் ஆப்ஷன்.
I mean, the reason why I asked this question was when a thing like this comes from a senior person who has done many things like this, it will give some confidence in younger trainees who are listening to this that ECT is safe in pregnancy. You can
very very safe. You have to take certain precaution because உங்களுக்கு வந்து இந்த ஸ்பிங்டர்லாம் ஈசோஃபேஜியல் ஸ்பிங்டர்லாம் ரிலாக்ஸ் ஆகும். So the post ECT வந்து aspiration during ECT or post ECT aspiration will be high. அப்புறம் வந்து என்னன்னா வந்து the placenta உங்களுக்கு யூட்ரஸ் வந்து இப்படி ஓவர் த இன்ஃபீரியர் வெனா கவர் இருக்குல்ல, அதெல்லாம் இருக்குல்ல, யூ கிவ் a left immediate ECT கொடுத்தோன்னே keep them left lateral eye கிளிக்கர் டைலேட் கொடுக்கணும். ரெண்டாவது ஃபீட்டல் மானிட்டரிங் நாங்க வந்து எங்கிட்ட இருக்கு. நாங்க we always monitor the fetus before and after ECTs. பட் ஆல்வேஸ் என்ன பண்ணா பேக்கப் வச்சுக்கிறோம். if anything has happened, இது வரைக்கும் நடந்தது இல்லை, ஒன்லி கேஸ் ரிப்போர்ட் ECT நடக்கும்போது டெலிவரி ஆச்சுன்றது ரொம்ப ரொம்ப ரேர். பட் anyway we should always in a safer side. ஏன்னா இப்போ வந்து each patient you have to consider as the litigant. All the patients are potential litigant. We have to document everything and we but personally I feel that ECT is a 7 months you can consider. No, nothing will happen.
Thank you, sir. Thanks.